Okay, so we're back, right? This is part 3 of sickle cell anemia. And the reason why, my new videos have a bunch of parts is because I'm trying to teach you how to answer case studies using clinical judgment. And while I may not have an unfolding case study per se, I've gotten all the 6 components of the clinical judgment um, used in each of these parts, I guess you could call it. So if you think of the intro or part 1 of sickle cell, we talked about recognizing cues, and then part 2 was analyzing cues and recognizing more cues. So of course, if you think logically, recognition of cues and analysis of cues always has to do with the patient's history, the signs and symptoms that your patient has, perhaps even some triggers that may have caused the disease process to present the way it's presenting in the case study. And so we're moving on, right? Because recognize cues was number 1, analyze cues was number 2. There's 6 parts of the clinical judgment model. And number 3 is prioritize the hypothesis. And number 4 is generate solutions. So when we talk about prioritizing the hypothesis, in my day, we called it rule outs. So the patient is presenting with A, B, C, D, E, F, G. Let's rule out, and then you had a whole list. When you look at the patient with sickle cell, if this is indeed the first time the family has ever been faced with sickle cell, it can be very much confused with other conditions, because so often the trigger of a crisis can be an infection and a fever. And so in that situation, you're most likely going to say, oh, well, this patient is presenting, or we're going to rule out on this patient the pneumonia, or maybe the flu, or maybe sepsis. So when we're looking to prioritize hypothesis, we have to figure out, how does the presentation of sickle cell crisis appear quite different from what you know about pneumonia, flu, sepsis? I hope that makes sense. So I'm going to use real life scenarios, because when I teach my students, I like real life scenarios. Conveniently or inconveniently, or I should say fortunately or unfortunately, sickle cell case met the media, I guess you could say. It was in the media. It was a high profile case in the media, and I'm going to read to you the information that was in the media. And then you can actually see how the recognition of cues and the analysis of those cues should have led her caregivers to do something quite different. So here we go, okay? We have an 8-year-old Honduras female presenting with flu-like symptoms while in custody at a migrant holding facility in Texas. The family originally arrived at the facility May 10th. A medical assessment was performed at that time. The family shared that their daughter had a history of sickle cell anemia and congenital heart disease. Now, this paragraph alone had a shitload of cues. So I hope you're rocking with your girl. Let's look at the ones I gave you. Latina ethnicity. She's a child of Honduras. And if you know your geography, which most of you don't, so I'm going to help your little ass with that, you would know that South America, Puerto Rico, Cuba, Mexico, collectively, we consider that Latina, female, Latino, male, sometimes collectively Latinos or Hispanics. By the way, they prefer Latinos, not Hispanics. And so this child is of Latino ethnicity. So now my next question to you, if we are implementing prioritization of hypothesis, is this information pertinent to these other categories? So I'll show you what I mean. Is it pertinent to sickle cell? Yes. Is it pertinent to the pneumonia/flu? No. Is her ethnicity pertinent to sepsis? No. So this is why I'm telling you that when you try to prioritize hypothesis, you must reflect back in this unfolding case study to the original presentation of the patient. So you have to look at the history, you have to look at the age, you have to look at the ethnicity if there is one, you have to look at everything. But let's continue. We said that she was in Texas. So I wrote Texas right here. Is the fact that she was in Texas in May pertinent to sickle cell crisis? Yes. Why, Shelly? Well, would you agree Texas in May is hot as hell? Is it pertinent to pneumonia? No. How about sepsis? No. So you're seeing how I'm prioritizing my hypothesis, trying to narrow it down and figure shit out. Y'all with your girl now, got to keep on going. The patient has not complained of anything yet. We simply described how she ended up where she ended up, but she did have a history of sickle cell anemia. So the family shared that with Border Patrol, but I'm going to keep reading to see what you think of her symptoms. Here we go. The child complained of abdominal pain, a cough, congestion, and a fever of 104.9 was determined for this child during a period of 3 days from the evening of 5/14 through the afternoon of 5/17, and this child was seen at least 9 times by contracted medical personnel. Well, let's see if any of this is in our little chart here, shall we? So the child complained of abdominal pain. Is, after what you've learned, abdominal pain part of sickle cell crisis? You better believe it is. Is it part of the presentation of pneumonia and the flu? Absolutely not. How about sepsis? No. Not classic sepsis, not classic pneumonia. So you see, we've got a bunch of Y's followed by a bunch of no's. So yeses and no's are making up our mind here, okay? Now, if we look at everything else that I threw in there, that is not part of this little girl's story. However, I do want to finish reading it to you because it's tragic. And I personally believe that it's tragic, not because these medical personnel wanted to kill an 8-year-old. No, I don't think that would ever really be true. I think it's because they did not recognize and analyze the cues that they were given. So we're going to continue. It won't have anything to do with some of this, but I'm using some of these as a typical symptoms of the typical sickle cell disease patient in any hospital or on your test. So let me continue. Her history includes sickle cell anemia and a congenital heart disorder, and the parents brought the documents outlining their daughter's extensive medical history and condition, but they were not reviewed by the actual medical personnel that were contracted to provide care. And they were not reviewed by those who interacted with this sick 8-year-old child. Now, I want to park right there just for a couple minutes because I have seen nurses. I have gotten handoff report at change of shift from nurses. I have seen nurses run in barely on time to punch in the clock. And I'm thinking to myself, for such a nurse running in at the nick of time just to be able to punch in, going to her locker and dropping off all this stuff and then coming back, racing out, sometimes running, to get report from night shift or day shift, change of shift, how likely is she going to be to have time to review this patient's medical history? You see, I don't know that I'm alone when I tell you that I got report from people who tell me that the patient is in dialysis or going to dialysis, but there's no history of kidney failure anywhere. Turns out it was an identification error. I don't know that I'm alone when I tell you that I've gotten a report on a patient that said skin intact and they got a big fucking stage 4 pressure injury in their ass. I don't know that I'm alone when I tell you that I've gotten a report that said that the patient was doing fine all night and that they're on telly, only to find out for 29 hours they ain't been on telly. Yeah, I said 29 hours. I don't know that I am alone in finding out that the patient needs an IV and get in the room and they already got 2. I mean, you know what I'm saying? This is dumb shit, but I'm just giving you all the shit that I see. So, as God is my witness, I need y'all to take it a lot more seriously than you currently do to review that patient's history. Now, let me give you some more love. This child tested positive for influenza A and was diagnosed with flu/fever, given Tylenol, ice packs, and a cold shower. I hope right about now you're so angry that you're throwing things at your laptop and your television saying, no way, Shell Bell. No fucking way did they get that baby with sickle cell ice packs and a cold shower. Come on over here. So we took a baby, y'all ready? With an infection, a high-grade fever. We took this child and exposed her to the extreme temps of fucking ice packs and a cold shower. I'm not sure that she was all that hydrated. I am positive because of her high fever that she was at risk for hypoxia. And all of this don't look like it plays a role because she damn sure went on no plane. She ain't pregnant. I doubt she's drinking or smoking. You know what I mean? Okay. Let's move on, shall we? I wish I could say I was done with this little baby, but I'm not. Numerous parental requests for an ambulance to the hospital were denied by the nurse practitioner. Jesus help me. Oh, okay. Nurse practitioner. Nurse practitioner. Okay. On May 17th, this child was seen 4 times by the nurse practitioner for difficulty breathing. Oh, there we go. There it is. Hello. Now we're short of breath. Can't even breathe. Mama told them that. She was seen by the nurse practitioner for difficulty breathing, worsening stomach ache, and nausea. Reportedly, this 8-year-old, I said reportedly. I wonder why I said reportedly. You ever seen crime scenes in the news where Joe Blow done raped 800 women and they say allegedly? I'm saying reportedly, because the shit sound crazy as hell. Reportedly, this 8-year-old had a normal heart rate and a normal blood oxygen saturation at each visit. All 9 of them. I said 9. Okay, fine, 9. At all 9 visits, the child had a normal heart rate and a normal pulse ox. On 5/17, same day. Remember, she was seen 4 times. On 5/17 at 2 o'clock, the mother returned to the health unit for the 5th time, this time holding her precious daughter, who appeared to be having a seizure. No shit, Sherlock, because what do you know about a temperature of 104.9? It's high grade, and it's highly likely to get his baby a fucking seizure. Now, come on now. Stevie Wonder and Ray Charles could see this shit. I hope you do. It's very irritating. I'm disgusted. Okay? Now, so mama returned to the health unit for the 5th time holding her damn baby, who appeared to be having a seizure, and guess what? Soon thereafter became unresponsive. CPR was started. The child was taken to the hospital and pronounced dead at 14:50. So by 2:50, 50 minutes later, after mama bring her baby the 5th time to your crazy ass nurse practitioner contracted to take care of this damn baby, 50 minutes later, she's dead. Upon an internal investigation, it was determined that the NP did not consult with the on-call physicians or the on-call pediatrician, and that numerous encounters with this family and numerous encounters with the family, the fact that emergency antipyretic interventions and administrations of medications were not documented in the record or disclosed. Some ghetto fabulous shit, ain't it? This is crazy as hell. You know it and I know it. But this is why I'm so hard on y'all, because I'm trying to tell you just the 3 things that I outlined about this story. It would have been so simple not to misdiagnose the child. She did have the flu, but she had a superseding sickle cell crisis. And like I told you in the other video, too many times people think of Black people with sickle cell. Don't forget the freaking Latinos with sickle cell. Y'all better recognize it's not just Black folks with sickle cell. Just like it ain't just white people with cystic fibrosis. Get a clue, okay? Do that for your girl. Now, let's tear up the club, because I'm trying to get you a license. I am putting some other things that have been, let's just say, appearing on different tests across the nation for your prioritizing of hypothesis. We're going to do this together. Now, I'm going to leave these blue, and I'm going to go ahead on and use some, let me use some yellow, some bright ass gold. Hypotension, sickle cell crisis. Yes, because you're damn sure anemic, and very often you're dehydrated, but yes. Pneumonia? No. Sepsis? Definitely yes. How about splenomegaly? Yes. No. No. How about acute chest pain? Yes. Yes. No. How about acute kidney injury, where your kidneys just said, fuck it, I'm done? Yes. No. Yes. How about jaundice? Would you ever see that with sickle cell? Hell yes. Pneumonia? No. Sepsis? Oh no. Bone and joint pain? Yes. No. No. Frequent admissions? Yes. No. No. What I'm trying to tell you is the way you prioritize your hypothesis, You've got to look at the labs. You've got to look at the signs and symptoms. You've got to look at the history, the demographics. You've got to look at the age. You've got to look at the gender. You've got to look at everything to see if it plays a role in you figuring out what this patient has. So I gave you this chart, and I hope you took a picture of my chart. I'm gonna get my ass out the way because this is a really good chart for you to know the differences between some of these diseases that you might think this patient has, like they thought that damn 8-year-old had the flu and that was it for her. Okay, so I'm just trying to help you out. Now, the next step, number 4, really easy. The next step is generate solutions. Here, the nurse is trying to think of her basic care and comfort. She's thinking about her S-bar. She's thinking about her precautions she wants to implement. She may be thinking about preventing complications or whatever. Just making sure that during this hospital stay, she starts thinking what I'm going to do to make this baby get better or make this patient improve their status. Okay, so what are we doing? Well, I got a trick for you, baby. It's called HOP. So every time you think of generating solutions, I want you to say to yourself, what is my plan of care? Because that's another way to say the same shit, different day. What is my plan of care for this patient while they're under my watch? Okay, now I got a mnemonic. Peep this. Way over here, HOP. And I give you certain meanings for the H, but I separated them because this one is a huge one. Okay, huge, huge. All right, so, but I'm going to give you the different meanings. And why is this separate? Because it's the first nursing action. And then I'm going to give you the other meanings for the others. Okay, so here we go. Y'all ready with your girl? Okay, here we go. The first H is hydrate. And we are hydrating our patient with an IV fluid bolus of isotonic solutions. Now, y'all know what the hell that is. That's your normal saline or lactated ringers or whatever. Okay, now why, Shelly? Why didn't you give the patient oxygen? Well, I do give oxygen with evidence-based presentation. Now, importantly, not with, this particular case study, but importantly, in the child that I gave you, the 8-year-old that I gave you, she was having difficulty breathing. That's an evidence-based presentation that needs oxygen. But you've got to be careful on the test and make sure there's a pulse ox less than 95, because 95 to 100 is normal, or the patient is short of breath, or they're having dyspnea, same thing, or they're having difficulty breathing, same thing, or cyanotic, same thing. You know what I mean? You got to have evidence before you slap somebody up the face, upside the face with some oxygen. I ain't got no damn evidence, okay? So in this situation, not the 8-year-old, but in this situation, ain't nothing over here talking about no damn pulse ox, okay? So we're just gonna assume, because you can't read into the question. If you don't see it, it ain't there. Quit reading into questions. Now, so my number one, no matter what's going on with the sickle cell patient, my first nursing action is hydrate. And that's why that H is all by itself. Y'all see that? That H is like, hey, how you doing? How your mama and them? Keep me separate, because you got to know some shit about that one, okay? Now, this H here is going to stand for everything else. Well, what is the H for? This H is medication called hydroxyurea. So I'm going to go ahead and write that down because I want my babies to know what that is. And hopefully you can kind of see up here. Hydroxyurea. Hydroxyurea is a medication that, if this is an adult, we might have that in our plan of care to give to the patient. A doctor has to order it, but still, that's a very common sickle cell medication. This is a chemo type of drug we'll talk about later, but that might be part of the deal, hydroxyurea, okay? The H also stands for, get this, heat. We need to keep our rooms for these patients about 72 degrees. Don't let them get in a room with a roommate who wants to shit on frostbite. That's not going to work. It's not that you need the room on cremate, but you need 72 degrees. Okay, that's about right. You also need to understand that warm compresses soothes the joints. I remember my patient, I kept bringing her warm packs, and she was putting them on her stomach because her stomach hurt, remember that? And she was putting them on her joints, knees, her elbows, everything, her shoulders, everything was in pain. And those, she said those were immensely comfortable. And I thought, wow, interesting. Okay, so it's really a big deal. So keep the patient warm. Now, why? What was it about that heat? Well, vasodilation. Remember that heat vasodilates, so that if you open the vessels bigger, and we're going back to the blood vessel that I drew on the board in the first video, if your blood vessel is bigger and dilated, then the blood can get through better and increase perfusion. When there's a constriction, there's a problem, because then you have the patient getting worsening ischemia. Let me remind you that the 8-year-old that I just read to you, that little 8-year-old story that just happened, right? It's not even been a month ago. These stupid fucks gave her ice packs and a cold shower. Now, come on now. So you know what happened to that baby. That baby vasoconstricted, became more ischemic, which caused tissue hypoxia, which made her bone marrow want to put out more red blood cells. The problem is there's a genetic condition making the red blood cells that the bone marrow put out sickled. So now the sickling has increased, and that made the hypoxia increase, and that made the ischemia increase, and that made the poor perfusion. I mean, come on. This is a vicious cycle. They killed her. They killed her with that bullshit generating solutions with ice. They killed her. I said H for heat. Keep the patient warm. Okay. Now, you have hydrated. You've kept your patient warm. You might have had to give the hydroxyurea. You've taken care of a lot of the triggers. So a lot of times, if you know the trigger or the cause of an infection, the triggers or the cause of a condition, you just look at them and reverse it, and boom, you got the treatment. So in the little girl, the only thing the dumbasses did half-ass right was they did give her Tylenol, but I mean, because if your patient got a fever, you definitely got to give them antipyretics. But other than that, nah, they fucked up. They killed the baby. Okay, now let's look at the O, because you know we got hop over on mnemonics and shit. I don't do a lot of mnemonics, by the way. So if my ass does a mnemonic, you better really take note, because I don't do a lot. Because I think that y'all confuse all them damn mnemonics, and then be like, what the fuck was that on the test? No, you're going to get a few from me, but just a few. So this one is H, hop. Here go the O. What is the O, Shelly? The O is oxygen, because we already sat up here and told you there is hypoxia. The O is also opioids. So the patient will actually need opioids for pain management. And the reason why I want you to hear me loud and clear is because if you consider what I told you in video 1, which is basically black and brown people gonna be your patient. These black and brown patients of yours are very often treated like shit because they're seen to be drug seeking. Because they already know what works. Half of them already are on opioids at the house. When they come into the hospital, they know what to ask for. And so because they're black or brown and they come in asking for Dilaudid, you've given them a label. I've seen it, okay? So don't bullshit me, because, it's not worth it. It really isn't. So I need you to be that girl who knows that this condition is so incredibly painful that the only medication to take away that type of severe pain is got to be an opioid. It could be a PCA pump. It could be around the clock, not PRN, hydromorphone. It could be around the clock, ATC, morphine, whatever the hell it is, it's an opioid. So I need you to just get with the program, okay? These are very, very, very serious situations because they didn't got to the point where y'all done called them drug seeking so much. The standard of care for most hospitals, get a patient PCA pump and sit down somewhere. Let them control their analgesia because y'all on some discriminating bullshit, okay? All right, so you got your O, opioids and oxygen. Now remember, your oxygen, you've got to have evidence-based practice. If you don't have a reason to give oxygen, then you shouldn't give oxygen. So make sure you're backed up with your evidence, okay? Now this P stands for pain because the pain is so severe. It stands for prevention in the first place, and it stands for positioning. And so in your plan of care or in your attempt to generate solutions, you are making sure that this patient keeps their extremities extended. They are not to have flexion. So the positioning for the patient is very important because when you flex, what did I tell you about the red blood cells? The sickle cells get caught up in these joints, causing the joint pain to hurt even more. But if you keep your extremities straight, you can have good blood flow and perfusion throughout these extremities. So that's what I mean by positioning. The head of the bed should not be up more than about 30 degrees. You don't want it too high because what are you doing? Creating flexion, okay? If we look at prevention, and prevention is a big deal because if you're in an outpatient setting, part of your plan of care is preventing the next crisis as well. So we always tell this patient that they should be drinking 3 to 4 liters of fluid a day, adults, right? And so when we look at the fact that we had to hydrate the patient as our first nursing action, when we gave them the bolus of the fluid as ordered, we did not take them down to like 75 an hour for their regular rate. We kept them at about 200 cc's an hour or 200 milliliters an hour of fluid. We trying to hydrate this sister here. So you're pushing fluids with this patient, 3 to 4 liters a day. You're preventing nightmares by knowing that most of these patients are going to be on, penicillin, BID, prophylactically. You know that this patient should treat any sign of infection really, really early. We know that all fevers are going to get antipyretics. We know that this patient is going to be told that avoid contact sports because of the trauma. We know that this patient will be encouraged to change up their lifestyle if they smoke or look like they're drinking every day. They need to nix that, right? And so we know that our females are not going to be given estrogen-containing birth control pills. We know that this patient needs a perinatologist before she becomes pregnant so we can manage her care in a way that optimizes the maternal child health. We know that this patient is going to be told about preventing DVTs, that she should have, TED hose or something like that put on her to prevent that. We know that we'd rather her drive on vacation, her and her family, with breaks every hour to walk around instead of flying. I mean, there's just certain things we know. We know that they need to be very careful with extreme temperatures. Why are you suddenly getting this intense desire to go visit Alaska? Are you freaking nuts? It's cold as hell in Alaska. Stay your punk ass down here in the States, here in the normal continental 49, I should say, so you don't have those types of extremes. Why are you going down south in the summertime? That's just stone cold loco. Just stop it. Okay, so we're just trying to help you generate a plan of care for this patient. We know that initially the patient's going to be on bed rest because in particular, moving around is going to use up oxygen. So they're going to have bed rest with bathroom privileges. They may need to be up with assistance, depending on how, you know, hypoxic or how low their blood pressure might be. Because when you're anemic like they are, you get dizzy. Now, here's something I don't want you to do. This patient will need some vitamin supplementation, especially folic acid. But what I don't want you to do is I do not want you to think for 5 seconds that this patient needs iron. If you gave this patient iron, you're actually going to cause an overload, and you might just have a problem on your hands with toxicity. So it might sound like, since they're anemic, iron is a great idea. It's not, okay? So no iron for this patient. In terms of their diet, well, their diet should be definitely fruits and vegetables and a regular diet. There's no real concern there. I would like to see a high fiber diet just to keep things moving, since the ischemia might be an issue for the GI system. But, you know, just a regular diet, right? Because we're talking plan of care, okay? So those are just some things to think about, and hopefully you got a lot out of this and you understand how we use clinical judgment in my YouTube lectures. So deuces. Again, don't forget the 8-year-old, because that's sad as hell.